In the previous tutorial, I explained why low lung volumes are bad, in particular why loss of functional residual capacity is not good because it results in hypoxemia. This time, I'm going to show you how to recover that lost lung volume by using PEEP or CPAP. Tutorial 19, Hypoxic Respiratory Failure, Part 8, Why we use PEEP and CPAP, Part 1. Welcome back. Previously we discussed the importance of functional residual capacity, and I explained that FRC is the resting capacity of the lung. It is an oxygen reservoir from which we draw continuously. It is also the point of optimal lung compliance, the point of optimal airway resistance, and it's the point of optimal pulmonary vascular resistance. Loss of FRC means low resting lung volumes, and that translates into hypoxemia. This time I will discuss how to restore functional residual capacity, and this can be achieved using either positive end expiratory pressure as part of a positive pressure ventilation strategy, or using CPAP, continuous positive airway pressure, where that is the only form of respiratory support. And I'll explain the difference between PEEP and CPAP. I'll also talk about PEEP or CPAP and pleural pressure, PEEP and lung recruitment, and PEEP and lung volumes. Before I get started though, I just thought I might mention historical anomalies in the nomenclature. It's important to understand that the term PEEP and the concept of PEEP arose in the 1960s, and it started being used in postoperative patients who'd had major surgery, had a lot of atelectasis, and physicians found that applying PEEP to these patients prevented atelectasis and improved their overall gas exchange. And that really evolved into a standard conventional approach to mechanical ventilation for hypoxic respiratory failure and all kinds of other stuff. And if you think about mechanical ventilation through the 60s, 70s, 80s, and right up into the 90s, most of the time the patients had an endotracheal tube or tracheostomy and were getting positive pressure breaths. Back in about 1981, CPAP was developed to treat sleep disordered breathing, and this was always non-invasive back then. And throughout the 1980s, CPAP was used almost exclusively in this realm. By the time the 90s came, the two different strategies of mechanical ventilation and airway support started to kind of convene, because the sleep doctors started using positive pressure breaths to help patients with severe sleep disorder breathing. So they got inspiratory pressure support to help the patients breathe. And patients who may have got intubated started getting CPAP as a way of stenting open their lungs. So the terms CPAP and PEEP had been used in different realms, and then they started to interchange a bit in the 1990s, and sometimes that gets a little bit confusing. I'll try and tease it out a little bit further later on in this tutorial, but let's start with a clinical scenario. You've been called to the PACU, and you will recall meeting Magella before. Magella is 54. She's a BMI of 54, and she's post-op open cholecystectomy. She's been back in the recovery room for 15 minutes, came back on 50% oxygen. She's in acute respiratory distress with rapid shallow breathing and saturating 88%. She has extensive atelectasis and airway closure, and having been given standard oxygen therapy initially, she was then given high-flow oxygen therapy, and this has failed. So how should Magella be treated? Not long afterwards, you were also called to the ICU, where you went to see Trish. Now, we'll recall Trish from before. She is a patient who has community-acquired pneumonia. She's been intubated and ventilated for 4 days. She's on volume-assist control ventilation with a tidal volume of 375 mils, a respiratory rate of 15, a PEEP of 5 centimeters of water on 60% oxygen. This translates to a saturation of 89% and a PF ratio, a PaO2 divided by FaO2 ratio of 150. Well, what should you do to get Trish's oxygenation back to something that you would consider safe? Well, in both these cases, we are going to either deliver or adjust her airway pressure at end expiration. And what we're going to do is we're going to give Magella CPAP and Trish more PEEP. So let's just look at the difference between PEEP and CPAP. Elevation in airway pressure above atmospheric at end expiration is known as PEEP. Elevation in airway pressure that occurs throughout the respiratory cycle is known as CPAP. Most of the time, PEEP and CPAP are indistinguishable, but it is possible to apply PEEP without CPAP in anesthesia, as I'll explain in a few minutes. Now, you will recall these curves from a previous tutorial where we looked at the normal breathing pattern, the sinusoidal flow pattern, the sinusoidal airway pressure pattern that essentially mirror one another. A slight negative deflection in airway pressure during inspiration and a slight positive airway pressure in expiration, but it all ends up at atmospheric pressure. So airway pressure varies depending on the part of the respiratory cycle, but it all varies around normal atmospheric pressure. When you decide to give a patient CPAP, we're going to raise that airway pressure above atmospheric, in this case to 5 centimeters of water. And in this situation, you can see that the waveforms look exactly the same. So you still have these sinusoidal waveforms for both flow and for pressure. You have a slight negative deflection on inspiration, a slight positive deflection on expiration. So it's still a normal waveform, but the baseline airway pressure here is now 5 centimeters of water, not 0 centimeters of water. And that's why it's called CPAP, continuous positive airway pressure. Remember that even though the patient is getting positive pressure to get them above atmospheric, their airway pressure in the flow waveform is entirely triggered by the patient, generated by the patient, and finished by the patient. The patient breathes normally. They have to generate negative pressure within the pleura to get air to come into the lungs, and then elastic recoil allows exhalation. And the tidal volume and the peak flow is entirely patient dependent. And that the tidal volume itself is based on the depth of inspiration. I'm now going to show you the one time that you can actually give a patient spontaneous PEEP. Now you can see here that the airway pressure starts at 0. So it starts at atmospheric. You have the normal flow pattern of inspiration and expiration. So we start at atmospheric, but then the airway pressure goes up higher than you'd expect. So it starts off low, and then just at the end of expiration it goes up quite high, and then it falls back to atmospheric pressure on inspiration. So how do you actually achieve this? Well, this is done in anesthesia if you close the adjustable pressure valve down just a little bit and the patient is breathing spontaneously. If you look at the screen here, you can see the flow pattern is a standard sinusoidal flow pattern. But look at the airway pressure. There's atmospheric pressure here. So the patient never leaves atmospheric pressure at baseline. So they don't have CPAP. But watch the airway pressure just go up and up and up here. At this point in time, the patient's receiving a PEEP of 8 centimeters of water, a mean airway pressure of 5. And so what's happened here is that at the end of expiration, the patient is breathing out against an obstruction. And this is what happens if you exhale and then just put your hand in front of your mouth. You basically give yourself some spontaneous PEEP. But then when you take a breath in again, taking your hand away from your mouth, your breath will start at atmospheric. So that's spontaneous PEEP. It's not a great idea. Some anesthesiologists do this to help the patient recruit up some collapsed lung tissue, and it certainly does that. But you can't leave this on because, first of all, the pressure tends to go higher and higher and higher, but also the tidal volumes drop because you impose quite a high workload on breathing. And so generally, it's really very difficult to give CPAP to a patient under anesthesia, so you're better off just giving the patient some low level of pressure support ventilation if you think that they need PEEP. This is what we understand PEEP to be, the springboard for a positive pressure breath. You can see that the patient is not triggering the ventilator, and the ventilator is time cycled. This is constant flow, so you know from previous tutorials this is volume control ventilation with constant flow. The breath starts at the PEEP level, it ends at the peak or plateau pressure level, and then goes back down to the PEEP level. So the difference between the PEEP and the peak or the plateau, depending on the mode of ventilation you're using, is the driving pressure. Normally in, say, pressure control ventilation, the driving pressure above the PEEP gives you the plateau pressure. In this situation, we have the patient breathing spontaneously and triggering a positive pressure breath. In this case, this is a pressure support breath. And you can see there is a slight negative deflection that is generated by negative pleural pressure relative to the alveolar pressure that is at PEEP. The ventilator triggers from that pressure so that the real driving pressure is the peak or plateau pressure minus the PEEP minus the negative pressure deflection. Hence, the mean airway pressure will actually be lower in this setting because the breath doesn't start at PEEP, it starts below PEEP from the point in the airway pressure that is generated by the negative pressure within the pleura. So spontaneous breathing patient on pressure control, for example, or pressure support will have a lower mean airway pressure for the same level of PEEP. So in many ways, when you're talking about the terms PEEP or CPAP, I think CPAP is actually a better term because that's really what we're doing when we're using mechanical ventilation. We're giving the patient CPAP and then we're building a breath on top of that. The positive pressure is maintained at that base level, which is the CPAP or PEEP, and it is maintained throughout the respiratory cycle. The CPAP level is the level at the beginning of inspiration and end of expiration and throughout. However, to be consistent with normal terminology, I will use the term CPAP for describing patients getting positive pressure through a face mask or a nasal face mask or even a tracheostomy using generally a non-invasive ventilator or some other device, and I will use PEEP when I'm referring to positive end expiratory pressure during invasive mechanical ventilation or non-invasive ventilation, where the patient will get additional flow during inspiration. Let's look at CPAP, PEEP, and pleural pressures. You can see on this picture the normal airway pressures. That's the green curve. There's a slight negative deflection in inspiration and a slight positive deflection in expiration. And with this, you can see the equivalent pleural pressure. That's the red curve. And the pleural pressure progressively reduces until end inspiration, and then it increases again due to the elastic recoil of expiration back to the resting pressure wherever that might be adjacent to that part of the lung. In this example, I've left it at -5 centimeters of water, but of course it's different depending on whether you're talking about the lung apex versus the lung base. In acute respiratory distress, the patient's work of breathing increases dramatically, and the patient may generate significantly greater magnitudes of negative pressure in the pleura to meet homeostatic needs. So in order for that patient to get the tidal volume that they need, they're taking huge respiratory efforts. This massively increases oxygen consumption alongside the work of breathing. By giving the patient CPAP, you're increasing the baseline airway pressures. The thoracic pump needs to work just a little bit less hard, so you can see that the pleural pressures have now moved upwards back to where they were to generate the tidal volume that you're looking for. And so the patient has less stress on their system, will work less hard and consume less oxygen. Now, the big difference between CPAP and PEEP associated with positive pressure ventilation is demonstrated here in a patient who is on assisted mechanical ventilation. Although they do generate a small amount of negative pressure in the pleura to trigger the ventilator, this is often minuscule compared with what is needed during spontaneous breathing. If the patient is on controlled mechanical ventilation, there is essentially no work of breathing and the pleural pressure remains static throughout. So all the oxygen that was being consumed by the respiratory muscles can be redistributed elsewhere. There's less oxygen consumption and therefore higher venous oxygen content. Now that we understand the impact of pleural pressures on airway pressures, let's have a look at a specific problem, and that is CPAP and the work of breathing. Here's a patient at end expiration. And we'll start here with the concept of atmospheric pressure. Atmospheric pressure we generally call zero, but realistically it is wherever you are in the world. At sea level it's 101 kilopascals, or 760 millimeters of mercury. But obviously if you live at altitude, that pressure is different. But that's the resting pressure in and around your airway. And at end expiration, the pressure within the entire respiratory apparatus more or less equalizes, so that the pressure of the mouth, just outside the mouth, down along the bronchi, all the way to the alveoli, essentially equals atmospheric pressure. There is slightly negative pressure within the pleura. It varies on what part of the pleura that you're looking at. I have randomly assigned the pleural pressure at -1 centimeter of water here, but of course it varies depending on what part of the lung is abutting the pleura. The greatest negative pressure is in the apex of the lungs, and the least negative pressure is in the bases in the posterior dorsal segment. So -1, just take that as a random number. Now when a patient inhales, what happens is the diaphragm descends, the visceral and parietal pleura are pulled apart, and the pressure within the pleura becomes more negative. This has the impact of dragging the alveolus open and generating negative pressure within the alveolus. In this picture you can see here there is -7 centimeters of water of pressure within the pleura and -4 centimeters of water within the alveolus. And as a consequence, as gas flows from high pressure to low pressure, gas flows through an open glottis all the way down into the alveoli, and that's how we inspire. Exhalation is a passive recoil process. So essentially what happens is the chest pump relaxes, so the diaphragm goes back up, the pleural pressure increases, the pressure within the thorax increases, and gas is pushed out along a pressure gradient into the atmosphere till it all starts again. But sometimes there is a problem with exhalation. For example, a patient may have bronchospasm, they may have COPD, they may have all kinds of junk in their airway. We frequently see this in patients in ICU who've got lots of secretions in their airways, and gas becomes trapped in the alveoli at end expiration. And because the lungs can't empty, the pressure within the chest collapses down these distributive airways, and you get dynamic airway collapse and positive pressure within the alveoli, and we call this Auto-PEEP. And in this particular cartoon you can see here that the pressure in the pleura is atmospheric, but the pressure that's in the alveoli is +5 centimeters of water. As a consequence, at end exhalation it is not possible to empty the alveolus. So at beginning inspiration, you've got a real problem here, that you have positive pressure relative to atmospheric in the alveoli, and in order for the flow of gas to move from the mouth all the way into this alveolus, that pressure must be overcome. And so what happens is the patient needs to generate a much higher negative pressure within the pleura, and in this case it's gone to -13, so it's significantly higher than where we started, and that just about overcomes the problem of the positive pressure within the alveolus, and it gets the pressure down to -2. It opens up all that dynamic airway collapse, and then of course gas will flow into the alveolus. Well, that's all very well, except for as soon as the patient exhales again, the same problem occurs. So the patient is really working very hard trying to get gas in, and then it won't empty. And sometimes the patient becomes more and more and more dramatically hyperinflated, because they just, every time they get a big breath in, they don't get all of that gas out. So this is a huge problem and a massive increase in the workload of breathing. And this is where CPAP becomes useful, because by applying a positive pressure at the airway that is above atmospheric, so in this situation we've put on 8 centimeters of water of PEEP on this particular patient, and now with gas flowing in to the patient's airway, we have a higher pressure at the mouth than the positive pressure that's trapped in the alveolus at end expiration. So it stents open that whole airway. You have this pressure gradient from the mouth all the way down to the alveolus. So even with positive pressure within the alveolus at end expiration, the positive pressure at the mouth is higher. So that stents everything open. It overcomes the resistance. And so when the patient wants to take a breath, it's so much easier because gas will flow. And you can see here that the pressure within the pleura is the same as it was for a normal inspiration. And that's why CPAP is really effective as a treatment for Auto-PEEP and for airway resistance, because it reduces the workload of breathing and prevents persistent and increasing retention of gas within the alveoli. Now let's move on to a slightly different topic, PEEP and lung recruitment. The purpose of administering PEEP or CPAP to the hypoxemic patient is to restore functional residual capacity back to somewhere near normal for that patient. And normal is 30 mils per kilo, or 2 to 2.5 litres depending on how big the patient is. To understand why we do this, we need to go back and do some revision. Gas always diffuses from where it's in high concentration to where it's in lower concentration. And in this cartoon, the green arrows represent oxygen. As oxygen is taken up from the alveoli into the blood, the alveolar concentration falls and the partial pressure gradient is generated for oxygen between the conducting airways and the alveoli, so gas continues to diffuse from the anatomical dead space into the alveoli during the entirety of the respiratory cycle. As we get older, our chest wall elasticity falls, and this leads to airway closure during FRC. With lung disease such as pulmonary edema that may be cardiogenic or non-cardiogenic, or consolidation, lung volumes fall and airway closure may occur during normal tidal ventilation. Once compression starts, oxygen diffuses as normal along the concentration gradient. As you can see here, the alveolar oxygen content progressively falls because it's not being replenished from the anatomical dead space. So that's going to keep on going until the oxygen content of the alveolus equals that of mixed venous blood. As oxygen uptake typically exceeds carbon dioxide removal, the alveoli progressively become smaller and eventually collapse. And this, of course, is known as atelectasis. The lung has a normal physiologic response to this known as hypoxic pulmonary vasoconstriction. However, in disease states, particularly when there is widespread inflammation, vasodilator metabolites may impair this process. And we can plot this on the oxyhemoglobin dissociation curve. We start with a normal picture where there is good matching between ventilation and perfusion, and you can see the point in the curve for arterial blood and for venous blood. Now look what happens when there is widespread alveolar collapse or atelectasis and perfusion is maintained through that area. Deoxygenated blood shunts through the lungs into the pulmonary venous capillaries. Because of venous admixture, shunting of venous blood into the arterial side, the systemic arterial blood saturation of oxygen is now 84%. Now when we feed that into the oxyhemoglobin dissociation curve, we can see that the resultant PaO2 is 60 millimeters of mercury or 8 kilopascals. So this is an example of right to left intrapulmonary shunt. How can we resolve this? Well, this is what happens with airway closure. When the patient inspires, they generate some seriously negative pressure within the alveoli, and they're able to suck in all that gas through the closed airways, usually, depending on, of course, on how much airway closure resistance there is, and they're able to replenish the alveoli and get oxygen into those alveoli, which then passes into the blood. But then, of course, during expiration, those lung units close when the pressure outside of the lung units is higher than inside the lung units, and you get this venous admixture. Now what we're going to do is we're going to come along here and treat this patient with PEEP or CPAP. So we're going to apply a PEEP valve and a positive pressure at end expiration, and what's going to happen here is we're going to splint open those closed lung units during expiration. So you can see what's happened here. The airway closure that had happened previously can't happen because the pressure that's being backfilled from PEEP into the airways is higher than the pressure that's closing the lung units and stents them open, and as a result there is less venous admixture in expiration. Let's see how PEEP and CPAP impact lung volumes. In our previous tutorial, we discussed lung volumes and capacities. I described 4 different lung volumes: tidal volume, inspiratory reserve volume, expiratory reserve volume, and residual volume. I also discussed 3 different capacities: total lung capacity, which is 80 mils per kilo, inspiratory capacity 50 mils per kilo, and functional residual capacity 30 mils per kilo. Although we can exhale down from tidal volume to residual volume, along the way gas gets trapped in the alveoli due to dynamic airway compression. This is known as airway closure, and the lung volume that comprises airway closure above residual volume is the closing volume. When you add the two, you have the closing capacity. As I've mentioned, airway closure results in venous admixture and hypoxemia. Anything that reduces FRC results in a greater impact of airway closure on the respiratory cycle. That might occur during anesthesia or lung injury. In this case, atelectasis occurs due to airway compression and oxygen absorption and results in a fall in FRC principally due to loss of expiratory reserve volume. Although tidal volume may remain the same, the closing volume may actually impinge on the tidal volume, requiring opening of closed lung units during tidal ventilation. Importantly, there is a fall in the total lung capacity, but inspiratory reserve volume may be preserved. Now let's look at an anesthetized patient who has lost lung volumes and is requiring a lot of oxygen to maintain saturations of over 92%. What we need to do here is perform a recruitment maneuver. It's worth mentioning at this stage that PEEP doesn't open up collapsed airways. You need a higher transpulmonary pressure to achieve that. In this case, we call it a recruitment maneuver. In this cartoon, you can see that there are many collapsed or partially inflated lung units. And what we're going to do is we're going to apply 30 centimeters of water for a period of time. In anesthesia, that's 10 seconds. And then these lung units are forced to open up. It's like blowing up a partially inflated balloon. So when we apply a recruitment maneuver and apply PEEP to this picture, what happens? As you can see here, lung volumes have been restored easily. You must keep in mind though that these are normal lungs. As a consequence, total lung capacity has been restored. During the operation though, these lung volumes may drift downwards, but assuming that you don't soak the lungs in fluid, they can be easily recruited again. This is the situation with our patient Trish, and it's different and more difficult. This is the patient with injured lungs who is struggling to maintain a saturation of more than 90%. Note that there is significantly more atelectasis than under anesthesia, and these lungs are inflamed and soggy. We're going to do a recruitment maneuver and apply PEEP or increase the PEEP, and let's see what happens. You will immediately notice that some of the atelectasis has been recruited, but not all. FRC has been recovered, and now FRC is above closing capacity, which will improve overall gas exchange. The saturation and the PF ratio should significantly improve. However, understand where this recruited lung volume has come from. Some of it has been reverse atelectasis, but much of it has come from the inspiratory reserve volume, and this always occurs in open lung approaches to lung injury. The total lung capacity has changed very little. So, looking at our two patients, Magella, the postoperative patient, has compression or absorptive atelectasis. She will benefit from CPAP through a mask or helmet, and this will help reverse atelectasis and restore her functional residual capacity. Trish, well, the treatment for her is to perform a recruitment maneuver, then increase the PEEP to 10 centimeters of water, and then reassess the situation. Did increasing the PEEP improve oxygenation? Did increasing the PEEP improve or negatively impact ventilation? Or did increasing PEEP cause hypotension? We will discuss these questions in future tutorials. Let's review this tutorial. We started off with a discussion about the definitions of CPAP and PEEP, and then we looked at the impact of CPAP and PEEP and pleural pressure. We elaborated on this by exploring CPAP and the work of breathing in a patient who had gas trapping and auto-PEEP. I then moved on to talk about PEEP and lung recruitment in situations where there was extensive atelectasis and airway closure, and finally we looked at PEEP and its impact on lung volumes in anesthesia and in acute lung injury. Next time, I will discuss PEEP and phasic shunting, PEEP and lung compliance, and PEEP and Auto-PEEP, including the waterfall effect. Join me then, and I guarantee you'll learn something. So this tutorial was about why we use PEEP and CPAP to restore lost lung volume and to improve oxygenation. If you're enjoying these tutorials, don't forget to subscribe at YouTube or join me at ccmtutorials.org.